Hey everyone, welcome back. Today's episode is a little different, and I mean that in the best way possible. Because the topic we're covering today, prior authorization and predetermination, doesn't just affect one type of person, it affects everyone in healthcare: the patient sitting in the waiting room, the practice manager buried in paperwork, the healthcare leader trying to figure out why their organization is hemorrhaging time and money. So today I'm talking to all three of you. Throughout this episode, I'll break down what's really happening and then give specific actionable advice for patients, practice managers, and healthcare leaders. Look for those call outs as we go. So buckle up. This one's going to make you angry, but it's also going to make you informed. And informed is exactly what you need to be. Before we even get to the authorization process itself, let's talk about something that most people, even a lot of healthcare workers, don't fully understand. Insurance companies have their own medical policies, and they are running the show. Every major insurance carrier, United, Aetna, Cigna, Blue Cross, you name it, publishes what are called clinical coverage policies or medically necessity guidelines. These are essentially rule books that define what they will and will not pay for and under what circumstances. Now, here's the thing: these policies are not written by your doctor, they're not based on your individual health situation. They're written by the insurance company, often based on population level data, and they apply to everyone. Here's the uncomfortable truth: the insurance company has already decided how they feel about a procedure before your doctor even submits a request. Your doctor might say, "This patient needs an MRI." The insurance company's policy might say, "We only cover MRIs for this condition after 6 weeks of failed physical therapy." That's the playing field. And if you don't know the rules, you're going to lose the game. For patients, go to your insurance company's website and look up their clinical coverage policies before any major procedure. It's usually buried under policies or medical policies. Search for your condition or procedure. You have every right to see the standard they'll use to judge your claim before they use it against you. For practice managers, your team needs to be reviewing payer medical policies regularly, not just when a denial hits. Build a habit of checking policies quarterly, especially for your top 5 procedures and your top 5 payers. What changed? What new criteria was added? Catching a policy shift before it causes a denial wave saves you thousands in write offs and rework. For healthcare leaders, you need a formal payer policy monitoring process. Assign ownership, whether it's your revenue cycle director, your managed care team, or a dedicated analyst. Someone needs to track policy. Updates across your key payers systematically. Reactive isn't good enough anymore. Build intelligence gathering into your operations. Okay, now let's talk about the two processes that happen before a procedure. Prior authorization, also called pre-auth or pre-cert, is when a provider contacts the insurance company before a service is provided and formally requests an approval. The insurer reviews the clinical information and issues a decision: approved, denied, or modified. If approved, authorization means the insurance company has agreed to cover the service, assuming all the other conditions of the policy are met: right provider, right place of service, right diagnosis codes, right modifiers. Approval is a start, but it is not a blank check. Predetermination is different. This is a request for the insurance company to estimate what they would pay if a service were provided. It's prospective, it's informational, and crucially, it's not a guarantee. But here's something that most people, even people inside healthcare, don't fully appreciate about predeterminations: they serve a second, critically important function beyond cost estimation. Predeterminations can be used to determine whether a requested procedure is actually covered under the insurance company's medical policy, even when prior authorization isn't required for that specific combination of diagnosis codes and CPT codes. This is a big deal. Just because a procedure doesn't trigger an authorization requirement for a given diagnosis doesn't mean it's automatically a covered benefit. The medical policy may still have criteria that need to be met. A predetermination gives you a way to test that coverage. Question before the procedure happens, before anyone is committed, and before the patient is at risk of an unexpected bill. Think of it this way: prior auth is the insurance company saying, "Yes, proceed." Predetermination is the insurance company saying, "Here's what we might pay, and here's whether this is even covered under our policy to begin with." Neither is a guarantee, but both give you critical information before you're in the middle of a claim dispute. These are very different tools, and confusing them or skipping predetermination because auth wasn't required leads to very bad outcomes. We will get more into this in the next segment. For patients, if your provider tells you that no prior auth is required for your procedure, that's good. But don't stop there. Ask them, has anyone verified that this procedure is actually covered under my specific plan for my diagnosis? A predetermination, where available, can answer that question before your procedure. If your insurer doesn't offer them, ask your provider to verify your specific benefits in writing. For practice managers, train your team to recognize when a predetermination serves a coverage verification function, not just a cost estimation one. When auth isn't required for a specific diagnosis and CPT code combination, that does not close the loop on medical policy coverage. Use predeterminations proactively to surface potential coverage issues before the date of service. Document the responses or the refusal to respond in the patient's account. That documentation becomes critical if a claim is later denied. For healthcare leaders, this is a gap that shows up repeatedly in retrospective denial analysis. Claims that bypassed prior auth because auth wasn't required get denied post service because the procedure didn't meet medical policy criteria for that diagnosis. The missed opportunity was the predetermination step. Evaluate whether your revenue cycle workflows include a coverage verification checkpoint for no auth required services, especially for high cost procedures. Closing that gap is one of the highest return improvements you can make to your denial prevention program. And here's where things get sneaky. Let's talk about one of the most dangerous misconceptions in healthcare: no prior authorization required. Patients hear this and feel relief. Providers hear this and sometimes assume they're in the clear. Both are wrong. Insurance companies are counting on both of those reactions. No prior authorization required simply means the insurance company does not need to review the service before it happens. It does not mean the service is covered. It does not mean the medical necessity won't be questioned after the fact. And it does not mean the patient won't get a bill. Payers can and do conduct retrospective reviews on claims that didn't require prior auth. They can still deny for medical necessity. They can still deny for lack of documentation. They can still deny because the diagnosis didn't meet their criteria. The absence of an upfront requirement does not equal coverage. The prior auth requirement being waived just removes one hurdle. It does not open the finish line. This is critical for patients to understand, especially for services like labs, imaging, and certain specialist visits, where providers are sometimes told no auth required and assume that means they're in the clear. They are not. And when the claim denies, the patient often gets the bill. For patients, even when your provider says no authorization required, call your insurance company and ask yourself, is this specific service covered under my plan? And if it's billed, what's my estimated cost sharing? Get a reference number from the call. You're building your own paper trail. For practice managers, stop using no prior auth as a green light internally. Implement a secondary step. Even when auth isn't required, verify that the service is covered benefit for the specific member under that specific plan. Not all members under the same insurance company have the same plan. Document the verification, not just the authorization. For healthcare leaders, pull your retrospective denial rate on claims that did not require prior auth. This number is almost always underreported because organizations focus denial tracking on cases that went through formal auth. If you're seeing elevated denials on no auth required services, your eligibility and benefits verification process has a gap. Fix it upstream. Let's talk about predetermination again, specifically the response many providers and patients get when they ask for one. We do not offer a predetermination. This sounds like a bureaucratic limitation of we just don't have that in the process. But let's call it what it really is. We're not going to commit to paying this claim before it happens. Insurance companies that decline to offer predeterminations are protecting themselves from being held to an estimate. If they issue a predetermination and later find a reason to pay less or nothing, that document creates liability. They simply opt out. For patients, this means no reliable cost estimate before walking through the door. For providers, it means no coverage confirmation in advance. And when things go wrong, and sometimes they do, the patients are left without any documented commitment from their insurer. For patients, if your insurance company doesn't offer predeterminations, ask your provider for a good faith cost estimate. It's a written estimate of the expected charges for your care. Federal law under the No Surprise Act gives you the right to this in many situations. Use it. Ask for it before every procedure. For practice managers, when a payer declines to offer predeterminations, document that response and communicate it clearly to the patient. Don't leave patients assuming coverage exists when no written commitment does. Consider building a templated patient communication that explains your insurance has not committed in advance to covering this service. Here is our estimate of your potential out of pocket responsibility. Transparency now prevents collection headaches later. For healthcare leaders, evaluate whether your organization is offering good faith estimates as required under the No Surprise Act to self pay and underinsured patients and proactively to patients whose payers won't pre commit. Your patient financial experience and your collections rates are directly impacted by how well you set expectations before a procedure. This is not just compliance, it's strategy. Okay, so we've covered a lot of ground already, and I want to bring in someone who has been living inside the process for a long time. Someone who knows the tricks, knows the traps, and has spent nearly 2 decades fighting for patients and providers in one of the most complex specialties in all of healthcare. I'm joined today by Dina. We won't use her last name because we do have a long-standing joke that she's in the WITSET program. She doesn't let us take pictures of her either, so I'm very lucky that I got to put her picture on this video.
Very.
Yes, very. She's a prior authorization specialist with over 18 years of experience. The majority of it was in interventional radiology. And if you're not familiar with IR, it's a specialty where procedures are incredibly complex, incredibly nuanced, and as we're going to talk about, frequently the target of one of the most frustrating denial categories in all of revenue cycle, which is called the investigational denial. So, welcome, Dina. I'm so glad to have you here.
Thank you. Glad to be here.
Great. Let's just jump into it, shall we?
Yes.
Okay. So let's start at the beginning because we do have listeners who are just brand new to prior authorization and they're brand new to revenue cycle. So let's think back of when you started, which is, I know, a while ago. But what do you wish that somebody had told you about the prior authorization process that you know now that is not actually what you thought prior authorization was when you started?
That is a great question, Heather. I think I'd have to say that an approved prior authorization does not mean guarantee of payment.
Okay, so explain that a little bit because I think that some people believe that, well, I have a prior authorization number. Why did this still not get paid?
And they do. I think they think that, along with not realizing that they could have lost their benefits.
Okay,
Um,
so like for somebody who is new, like maybe a patient who doesn't understand, because we do have this channel for patients and for professionals. Expound on that a little bit. Like how does a patient lose benefits?
it could be loss of job. It could be a premium not paid. So even though we check it when they're a new patient and they first come in and we verify eligibility, it does not mean that that has been maintained. So before
Okay.
their appointment, we should always be responsible to check their benefits again.
Okay. And obviously, I mean, I think that we have experienced many times where we try to say to patients, always tell us when you change your insurance, right? Because a lot of times as practice, administrators, we don't know when somebody's changed their insurance. So you might go down a path of doing an authorization for insurance that maybe was the secondary but used to be the primary because somebody got a new insurance. Does that happen often?
It happens more often than what you'd realize. And I believe patients don't even think to tell us that their insurance has changed. So it does need to become our responsibility to verify that.
Okay. Yeah, that totally makes sense. So pretty much just knowing that a prior authorization is not a guarantee.
It is not a guarantee. We still need to make sure we check their benefits, submit the claims on time, and do our part, work together as a team.
Okay. Great. Thank you. Okay, you work in interventional radiology, which is not exactly where most people start because of how complex that specialty is. But the habits you build early matter regardless of like what specialty you're working in. So, what does a rock solid prior authorization submission look like? The kind that minimizes the chance of a denial before it even happens.
I would have to say a rock solid prior authorization submission hinges on precise clinical and knowing that payer's criteria. You need to work with your clinical staff to fine tune the clinical to include any criteria help that will help in a positive and quick turnaround.
Okay. So for our newbies out there, how does one find the insurance criteria for a particular procedure you're trying to get authorized?
There are some insurances you can request it from, but it's also usually found on their website or you can find it online. And
Okay.
it will spell out what they're requiring as far as conservative measures or if there's certain sizes for the IR procedure that
Okay.
will help you meet that.
So pretty much you can go into an insurance website or request, and like if you're on the phone, you can say, "Can you send me the policy for that?" Or if you're on the website, you can type in a CPT code and be able to find a policy that tells you exclusions and all of that.
Yes, you can, and you should check it frequently. They will change them or update them from time to time, so it's always good to log back in or to, look on the website for their policies.
Okay, that's good to know too. Um, what documentation? I mean, you kind of talked a little bit about criteria. I mean, what documentation do you know oftentimes trips up the process of a prior authorization? Almost kind of like it kills the denial, but it kills the authorization before it even starts, so that you get denied.
Yeah, it's not always that the documentation isn't complete. It's just sometimes hard to read or understand. It's really good to outline your clinical, to follow along in their steps, to make sense as as it hits the nurse's desk. It just makes them more aware and able to line up your clinical with their policy.
Okay, you kind of touched a little bit on something that I think that a lot of people assume that when you're doing a prior authorization, that it's the doctor who's making the decision as to whether or not something gets approved. I think patients sometimes think that, well, my doctor told me I needed to have this, so this should be approved by my insurance. But also, what you're saying is that it's not even a doctor on the insurance side that's always making that decision. Kind of explain a little bit on that.
No, it's usually a doctor or a higher up medical staff that has defined the policy, but it's going to be a nurse or other type of clinical staff that will be reviewing it. And if they can look at your clinical against their policy and basically go check, 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 it is going to be much smoother and easier for them. I've actually had them comment before that they have appreciated the way our clinical is easy to read, easily defined, and just helps them out. It's not necessarily their specialty that they've ever
Okay.
even been in.
Yeah, I mean, I think that's really important too for listeners to understand is that, the insurance companies, they have these, nurses and these providers who are oftentimes reviewing something that they didn't even go to school in. That's not where their career background is in. And so these policies is pretty much what guides them.
Exactly. Especially when you're talking about interventional radiology. There's a lot of people, including medical staff, that are not familiar with the procedures.
Okay, so here's one that I really want to dig into because it comes up constantly in IR and it's one of the most maddening denials in revenue cycle, the investigational denial. The insurance company looks at the procedure, one that's being performed nationwide, one that your physicians have been doing for years, one that's become the standard of care. And they come back and they say, we considered this investigational. What is the insurance what's actually happening? Like, what's the insurance saying there? What's going on? Why does that denial come through? And why does it happen so frequently in interventional radiology?
This is a tough one.
It is a tough one. That's why I want you to answer it because I don't want to try to answer that one.
Okay. When an insurance company issues an investigational or experimental denial for an established interventional radiology procedure, it means they have determined the treatment lacks sufficient high quality clinical evidence to prove it improves the health outcome, what we're saying that it will do. In plain terms, the payer is claiming the procedure is still a science experiment and that it's not a standard of medical policy or practice. An investigational denial is rarely about the specific patient. It's a systemic policy-driven rejection happening at the corporate level.
Sometimes you don't know if an insurance is going to cover a procedure or not, especially with interventional radiology because things change so often with what can be done for a patient. And so What's your gut feeling? Like, what is your gut response when you get a denial for investigational reasons?
Well, total frustration. I mean, I it's frustrating on many levels because first of all, you believe, you know that this is a help. And then second of all, you start to feel helpless in a way because overturning an investigational or experimental procedure can be next to impossible.
That was gonna be my next question is that what what is there, if anything, can a prior auth specialist or a practice do to even fight against an investigational denial?
Well, after getting over your frustration of it, you can pull articles from a peer to peer review. You can try to get information from journals or national clinical practice guidelines to try to do a letter of medical necessity that a physician can help you write up as well that
How often
shows.
do you see that work?
Unfortunately, not as often as we would like. It would be nice if the insurance companies or those who are writing the policies would look back into things and see that it's not just a science experiment, that they would look at the evidence that shows how effective or helpful this procedure can be.
Oh, that's even something that I was gonna ask, and maybe I'll ask it now because I don't know if I'm gonna ask it later, but how often do you see these insurances, reviewing their policies and making changes where their policy has been listed as investigational for years and years and years, and do you ever really see them make a change where something now is not considered investigational?
I can't say that I haven't seen it happen for the positive. I have seen insurance companies actually start to cover it. They may have different requirements than other insurances that need to be met, like defining the size of the ovarian vein or saying that it's pelvic congestion, that's seen and proven by a CT or something like that. But there are other companies who are just, in my personal opinion, who don't even consider looking into whether this is a helpful procedure or not.
Okay, so pretty much some of them are a shutdown just automatically, but basically because you have seen some positive, there's maybe some rays of hope that don't give up necessarily when you get an investigational denial as setting that as your standard for that payer for years and years to come. You're saying that sometimes they will make a change to their policy.
Oh, yeah, I think so for sure. And that's why from time to time, it's always good not only to look at the policies again, but to submit. You never know what changes could have happened that you're not even aware of yet. And so, even though you know it's a payer who may not cover, it's always best to submit. And, a patient can always jump in too.
How do you recommend patients to jump in and help?
You know, I have said for a long time that the patient's voice is key, especially once something has been denied. We look as providers who are just maybe wanting the financial component of it, which isn't true. We believe the doctors believe in what they're doing and they are helpful, but a patient, it's their insurance and they need to write letters or call and hound. It's affecting them and they need to hear from the insurance company how it's affecting and hopefully get them to open up and look at, relooking at these procedures.
Right, patients are their best advocates for themselves with their
Yes,
insurance.
and I wish that, they understood that, but it's very scary.
It's intimidating.
Yeah, very intimidating, even for those who do it for a while, it can be intimidating, but all they need to do is explain how they're hurting or how that they want their life to improve.
I always want to bring it back to the patient because at the end of the day, that's who this affects the most. In your experience, what do patients not understand about what's happening behind the scenes when their authorization is being processed? And what do you wish you could tell every patient before their procedure?
Well, I wish I could tell them that the decision, the denial, it's not a medical verdict. I think patients, they hear that the procedure was denied for whatever reason, whether it was investigational or they're not meeting the criteria fully. They will internalize that and they'll think that, well, my doctor is wrong or this procedure is not necessary, that they don't need it, or they're thinking that the prior authorization specialist doesn't care enough or that they did something wrong with their authorization. And what they don't realize is it's a generic corporate checkbox failure. They're trying to do the delay
The
tactic.
delay of care.
Delay of care. And so they're intentionally trying to stretch it out or frustrate, you know, either the provider or the patient and hoping that someone gives up and abandons care.
I think that, like, you're just touching on that, right? Is that they're planning on somebody giving up, right? Like that the
Yes.
automatic denial, that might not be like the final decision, but it's a tactic to get somebody to maybe give up on that trajectory of care that they were pursuing. And so it saves the insurance a little bit of money on that side of things. So with that, can you tell me, have you ever had a case where a patient's own advocacy, like where they called their insurance, where they asked questions, where they pushed back with their insurance on their own, actually changed the outcome?
Yes, I have seen it. We actually had a patient at one point who took their denial and fought their insurance company. They spoke up, and it actually opened care for other patients. They were actually willing to discuss the procedure and the benefits of it on this patient, and they didn't only approve it for them, but they were willing to rewrite their policy to, include the procedure. So it is helpful.
So patients still have a voice with some of these situations. Some payers will listen. You know, we can't guarantee always, but it's not just we're saying don't always just give up.
No, don't always give up. They have the loudest voice. It's best for them to advocate for themselves.
This has been one of the most valuable conversations I think we've had on this channel. Thank you for pulling back the curtain on what this actually looks like, the strategy, the grinding detail, the advocacy, and honestly, the passion it takes to do this well for 18 years. For everyone listening, the kind of expertise she just shared with you is not common. It is built over years of denials fought, appeals written, peer to peers navigated, and patients protected. If you're building a revenue cycle team, this is the standard you're aiming for. If you want to hear the full conversation, which is about 45 minutes, not what was been in this episode, the link is in the description and the comments below. All right, everyone. I have to be honest with you. When I sat down and put this episode together, I knew this topic was important. What I didn't fully anticipate was just how much ground there was to cover, and I refused to rush it just to fit it into one video. You deserve better than that. So, we're going to do something a little different. This is going to be a two-part episode, and because I don't want to make you wait a full week, part two is coming out very soon. Here's where we've been today. We talked about what insurance companies are really doing behind the scenes before your procedure ever happens. We broke down the difference between prior authorization and predetermination and what it really means when a payer tells you they don't offer one or won't commit to the other. And we sat down with Dina, a prior auth expert who gave us a view of what it looks like from the inside. That was a lot and it was important. But here's what's coming up in part two. And I promise you, this is where it gets real. We are getting into the ugly side of this process, the delays in care that puts patients at risk, the provider burnout that is quietly hollowing out our healthcare workforce, the invisible administrative costs that nobody's talking about, and ultimately, the part that is a big problem, the patient being left holding the bill. Please do not miss part two. Subscribe if you haven't already, turn on your notifications, and stay close because it's dropping soon and you don't want to come into the conversation cold. I'll see you on the next one.